just talks about what you guys just did. So for the head, okay, key points of control at the head, you can kind of use the ears and rotate back and forth. If you go this way, you'll bring a person to standing. If you go back too far, though, you're going to facilitate this. So, and when people normally go sit to stand, they tuck their chin a little bit and then they untuck it. Does that make sense? So you have to always think about what is normal movement like. Now, at the shoulder girdle and rib cage, if you retract somebody, you're going to facilitate complete body extension. So if a person already has this kind of spasticity, you want them in the opposite position. Posterior pelvic tilt, forward flexion. So when they go up to a stand, you're going to bring them into flexion so they don't do just what you don't want them to do. Pelvis, I think we talked about this in kinesiology, but remember the pelvis tilts forward and backward, the pelvis lifts side to side, and the pelvis rotates. And if you think about people who have hemiplegic gaits, they are not moving their pelvis at all. And so your goal is, come up here, Christina, over here. So walk like this, like you're hemiplegic. Yeah, come over here. Okay. So very good acting. Okay, let's walk that way. So I'm going to tell her this is how it feels to weight bear. And then I'm going to add some rotation. So I'm going to facilitate down, I'm going to facilitate rotary movement, and then I'm going to, if I need to, I'm going to facilitate pelvic tilt back and forth. Does that make sense? So, yeah, we're not a PT, but anybody walking or standing with the patient should be giving them that input so they learn where their body is in space. Okay? It's really about giving people proprioceptive input. Okay? Now, positioning in NDT is always to position so you're going to inhibit those reflexes. So we said if somebody's like in this extension synergy, you want to put them in flexion synergy. So you're going to use pillows to put them forward into flexion, for example. If somebody's in flexion synergy, they're all flexed in this fetal position, you want them supine and let gravity do the work to get them into extension. Does that make sense? So just think about where they are. Also, in nursing homes, you really not allowed to use restraints unless you have a doctor's order. But even with a wheelchair seatbelt, if a seatbelt, any kind of seatbelt or belt, like they're sliding out of their chair, right? And so you put this sheet around them or something, and you put it around their waist. What are they going to do? They're just going to push out against it. So really where it needs to be is in the pelvic area, right at the hips, to pull them back into posterior or anterior pelvic tilt. Does that make sense? So really think about, when they say on the plane, put it low and tight. That's what you want with the seatbelt. You don't want it up here because you're just going to encourage a person to slide out of their chair. So think about where those positional things are. We talked about weight bearing, shaking, or quick alternating movements like I was doing with Keith. Go up, now go down, go up, go down, go up, go down. That trains muscles on both sides of a joint. Approximation or joint compression, where we did over the ball, right, where we did this place and hold. Now the last thing that we didn't talk about was kind of what I was doing to Allison, which is traction. Her joints are jammed up into the sockets, so this is the one case where we might pull on a joint to stretch the joint capsule a little bit, so we're doing traction. Does that make sense? Okay. Tapping. We did not do tapping, but tapping, Sarah, come up here for a minute.
Can we move that
I'll
table
show
right
you,
there?
huh?
Can we move that table right there?
This table?
Yeah, sort of.
Move it to this, towards Nikita.